So it is nothing but the cam type of deformity, and that is the reason you can see these arthritic changes at the another head neck junction. It's like something like a mushroom head. You can see this both in lateral view also, lateral view also. So the mixed type. Now in the normal is this mixed type. We have a coverage plus additional head neck junction. So we do have a double pathology here, and that's called as a mixed. So we discussed with first pincer, second is we said a cam. Now the third is mixed. We have got double pathology, that is a acetabular over coverage as well as a head neck junction abnormality, either offset or something like that, which is there. So clinical history in these patients are slip capital epiphysis, Perthes, DDH, and post-traumatic also can develop the picture of a mixed picture. What are the symptoms of these FAI patients? The incidence onset of groin pain, very classical, they have a groin pain, which will come to do what is that C sign. Higher activity most patients are in higher activity participation. They have repeated motion, high flexion, abduction, rotation, very, very excessive movement they have usually. And that is the reason they will come into that action of that repeated trauma. In ordinary, they may not be using the full hip movements. Symptom provoking hip position and movement. And classically, they will tell you, this is the only moment I have, it bothers me. Otherwise, I'm okay. Mechanical symptoms, catching, snapping, clicking, popping. One of the symptoms may occur. Pain is worst on prolonged sitting. Location of the pain is either anterior or slightly on the lateral side. And routine hip examination, and also you have to do the opposite hip examination, neurological examination to exclude lumbar pathology, as usual, knee joint, hip above spine. So you need to examine all this. So what are these provocative tests are? So the first test is FADIR. Is a very classical flexion adduction internal rotation test. Okay. The second stage is abduction, extension, and external rotation, where the posterior impingement takes place. There it is anterior impingement takes place in flexion. In extension, you get a posterior impingement, and that is known as a Stinchfield test. Passive SLR to 45 degrees. Recreation of the pain due to psoas pressure on the labrum is possible, but may not. We don't use this test so commonly. If you want now this provocative test, we have to do this very rarely. Sometimes is a real pain or some other pathology. So we can differentiate by injecting local anesthetic under image amplifier under the hip joint. And you test again the test. That test becomes a negative because the local action has taken place. So that is the way we can actually differentiate the pain coming from the hip or maybe other source. So you have to have, and that usually gives around 90% accuracy, not 100% accuracy. So this is a classical C. Look at this gentleman who's coming with this is a classical, the hand he puts. Ask the patient, where is the pain? He'll just put a hand like this. So that's a classical C sign. Anterior impingement, that indicates anterior impingement. And you see this is a flexion more than 90 degrees. Adduction. And look at this, this one. Oh, rotation. Internal rotation. Classical of where exactly patient will tell, yes, I got a pain. So that's a provocative impingement sign. And for a posterior impingement, you have to take the patient on the either side or something like this side and force the external rotation and extension. And that becomes a posterior. Either it is called a Steichman or it's called the Derman sign. One of the name differently has been quoted. So these two important signs we will check. So anterior impingement, posterior impingement. These are the only two important signs, provocative signs you have to see, and that will give us enough diagnosis. Condition that can mimic this. That's why we have to be very careful because we see a lot of patients abnormal morphology, and that may not be symptomatic, which I will come to you. Very important paper which have been from India, because on X-ray you see some signs. Patient will not have any pain. Whatever you do moment, they will not have any pain. That not necessary. These signs are related to the pain. That's why we have to take it very with pinch of salt. So other part has to be excluded. Back pain, lumbar problem, sacroiliac condition, iliac apophysitis, iliopsoas tendinitis, trochanter bursa, all sorts of things. The sprain of the abductor muscle, hamstring tendinitis, so many factors around the hip. You have to exclude before you label that gentleman as a FAI. Treatment is usually conservative. Most you have to ask them to avoid the action which causes the pain. So they will have to modify their job or activity, whatever they want. So that is very important. Otherwise, they will go into repeated phenomena of early arthritis. Second choice, those who are not settled down or those who are really getting mechanical symptoms. It's a mixed type of picture, mechanical symptom. I think arthroscopy of the hip is one of the things which works beautifully. The second is the joint preserving surgical approach, which was, I told you, Gans was the one who developed the anterior dislocation for FAI, and he was correcting, taking out the extra addition head neck junction. He was repairing the labral, and then he was putting the hip back. So that is a anterior dislocation, which I will just go to show you one example. What is non-operative? Physical therapy, improve abductor strain, NSIDs, activity modification. No data today support it will stop arthritis. So I think it's just for namesake for 6 weeks. As the patient has come, we'll allow them to do certain things. It may not work. So arthroscopy came with vengeance in 2003 and 2009. 18-fold increase in the hip arthroscopy in USA after the FAI came into the picture. Significant number of FAI patients will develop early degenerative arthritis as FAI is a precursor. So a lot of arthroscopies were done in USA. Now today, we have toned down completely now. We will only do a patient who are really symptomatic and where it is only possible to tackle this. Otherwise, hip arthroscopy, what used to be in previous, it is not been done now. And now something like Elizora came in vengeance. Now today Elizora has taken his own place. Same thing, hip arthroscopy, people started right and left. Now it has its own place now. The role of hip arthroscopy, a symptomatic individual, I told you, failed to respond, and early, very early, once they develop an arthritic stage, joint reduction space and other, it doesn't work. Early diagnosis, early treatment is paramount to stop this progress of the osteoarthritic. The arthroscopic protocol are standard table, examination under anesthesia, see the range of motion, do intrafluoroscopy with various angles, well-padded boots, 6 to 8 millimeter distraction of the joint has to be taken place so that you can put the scope inside. Traction less than 1 hour, which is ideal. Otherwise, you have a problem of pudendal nerve palsy. So don't use this a longer time, because initially all the arthroscopists they took a lot of time, and this was the problem with the neuropraxia of the pudendal nerve. So portal are anterior lateral, 1 to 2 centimeter anterior, and 1 to 3 centimeter proximal to the tip of the trochanter. You may not remember all this. So some of the portals you can say that usually the anterior portal is the most common, and second is the mid anterior. So what is done usually, You see here, there is a burr, especially you are taking out the junction. There's an extra additional junction here, the head neck junction. We'll have to just trim that area. So we have one portal is there and another is working. So that's the way, that's the labrum. And you see the tear of the labrum which has taken place. This can be sutured. The labral tear can be sutured through an arthroscope. Outcome: few complications, fast recovery. Poor outcome in narrow term space, high grade of damage, cartilage seen in a preoperative MRI. Third is long duration of preoperative symptoms. They are not good patients. Complication: aortic injuries to the labrum. Post surgery, they have a lot of ossification has been reported, myositis type of ossification. And once that develops, I think the results are very, very poor. Instability. People have reported dislocation also, but we have not seen any. Femoral neck fracture. Once you do too much of damage, femoral neck fracture. AVN, intra-abdominal fluid exudation can take place because of your portal of entry. Neuropraxia, pudendal nerve, inadequate correction. These are some of the complications. So joint preserving surgery approach, surgical approach, is called as a safe dislocation. The Gans described what is called as this was called as a safe dislocation, anterior dislocation. So deep branch of middle circumflex artery on that trochanteric flip osteotomy is done. What they do, resection of that extra bone head and neck junction. The acetabulum also they trim, and suppose there is a retroversion of the acetabulum. So he will do a reorientation osteotomy. And if suppose there is a retroversion of the femoral head neck, so they will do valgus osteotomy also. So this is the way it is done, a combined procedure, debridement, nebral repair, chondroplasty, and additional procedure on the either acetabular side or femoral side. It doesn't work single-handed. So you have to do a combination of work depending on the pathology. So this is what is done. That's your anterior. This is a trochanter. This is your abductor. This is the vastus lateralis. We take a sliver from here. We just with an osteotomy or saw. You see here this is the saw we're using. So the whole abductor, that area is shifted. So this is the gluteus medius. That's the gluteus maximum there. This is anterior. We are not going behind. This is the only structures is seen. Okay, and we lift this whole thing and we'll dislocate this hip anteriorly. Okay. Then we once the capsule, we'll take something like a Z type of capsule, lift the capsule up, we'll dislocate the head, dislocate whatever you want to do, labral management of everything can be done, and put the hip back. And you either staple or put two screws, whatever the way you want to fix, you can fix this. So this is the way the head neck junction is cleared. That's called as either femoral or acetabular osteoplasty is done. Either on the acetabular side, if there's an overgrown here area, over coverage, you can just take it out a little bit of, trim that area. So significant proportion of the population with radiographic finding of FAI are asymptomatic. I just now told you, they are asymptomatic. Which are them will progress to symptomatic arthritis? We really don't know. So I think the time is going to tell us what is going to happen to these patients. So they are fairly asymptomatic. We see large number of population with one of the sign of FAI. Either most commonly we see quite a number of CV pincer type. Cam time is not common in our country, which I'm going to share our experience. So what are the final radiographic report? We do it on the femoral acetabular. First is crossover. Second is the prominence of the ischial spine. Os ossicle. Center edge angle changes. Alpha angle changes. Femoral offset reduces. Pincer sign. Cam sign. Mixed pathology. Pistal group deformity. Acetabular index and extrusion index. And CCD angle, that is a Coxa-Vara angle. So these are the couple of things we look at it. You're going to have some repetition here. So what happens? This is the first study of the country in India that we thought we'll do multi-center study on FAI. So we invited from south, north, east, west centers to come to one place at Shalby. And this is one of the radiologist from Mumbai, Aditya Daftari, who is trained in USA, a special surgery hospital, one of the very top leading radiologists. We took his help. We brought him, everybody brought on the same platform, and we trained our all these doctors from across how to take an X-ray properly and how to report them and how to analyze them. And everybody has to use the same software. And final analysis is done partly by me and partly by Daftari. And that's the way we worked on FAI project. And this was sponsored and supported by Indian Hip and Knee Association, Indian Society of Hip and Knee Association. And this is what we did. And we did a 500 asymptomatic population. We took it. And all were younger, less than 40, where they had no surgery before on the hip. They had no symptoms of the hip. So they were picked randomly at all the centers. So again, I'll come to that. We look at the crossover sign. These are our own patients. And to our surprise, out of 500, we discarded other numbers because the X-rays were not proper. They were not either in rotation, somewhere other thing. So we discarded some about 24 or 25 X-rays. So they were positive in this crossover sign was positive in 118 hips out of 476 with no symptoms. So 24% had something like this. The male were much more than the female. So I told you the pincer is much more, in India is slightly different than what Western world is. Okay, so the male had much more pincer. The second sign was ischial spine. Look at the prominence of the, and look at this prominence, such a broad prominence. And all patients had were guided by a lead sheet, the gonadal sheet, all the patient. That was a protocol, okay? So you see the very broad and large ischial spine bilaterally. And these were positive in 80 out of 476. So the percentage was around 16% was positive patients of ischial spine. And again, told males were much more than the females. So DERS pincer has much more than the males in our country. Then posterior wall sign, normal, which I already explained you. So I'll just go this way, fast. So this was not very common. So the protrusive effect was not, only seven patients, very, just less than 1.5%. So posterior wall sign was not very much in India. Os ossicle, that was a calcium. We saw in 17 hips, os ossicle out of 470, 3.6%. Again, males were slightly much more than the females. Then the next was the pistol grip deformity. You see, this is the pistol grip deformity very clearly. And it is bilaterally, both sides this patient has got. Okay, and we just saw this pistol grip. And this was not very common again in our country. So we got just 14 hips out of 476. So it was just 2.9%. Again, much more in the male patients than the females. And then lateral center edge angle. You look at this. This is the amount of work we did. So much of calculations. Abnormal is more than 39 degrees. So we got a good number of patients. We got a center edge angle was much more. So 15%, which is very large numbers. Center edge angle. So we do have this center edge angle was much more. So again, the male population was something which is much more in FAI. Then we did a Acetabular index. Was positive. Normal is positive. Negative angulation indicates the deep acetabulum, and we didn't had males, but almost 55 patients, 11%. Male population was much more. we looked at the extrusion index of this A upon E, all the measurements. Look at the, we use very sophisticated software for these patients. So we do had almost average was 0.92%. Then normal, this alpha angle was normally it should be less than 50 degrees. More than 50 indicates there is a cam deformity. And you can see this is the cam here. This is abnormal. Can you see the bump here? Large bump there. So we saw around 48 hips out of 476. We saw around 10% of this area where showed this. And male were slightly more than the females. The offset we could not measure properly because we had a problem of radio marker. You see the radio marker, we have put all the patients radio marker also. So we were not able to get a good magnification in lateral X-ray. So this study is does not related to offset. But just to remember, all of you, if the offset becomes smaller, that means impingement will take place. Less than 8 millimeter, you just keep that in mind. So I already mentioned drawback of this marker was inconsistent. That's why we were not able to actually measure this. So finally, we came with a certain new classification. This classification is not described in the book. This is our own classification. What we described, abnormalities. One is acetabular overcoverage, that's called O. Acetabular retroversion, so rotation is R, and femoral head neck junction was a C. That is the way we classified ORC. Okay. And to our surprise, look at the data. Acetabular overcoverage, C angle 15%, index 11% different, crossover sign 24%. So these are the people who come in between this. That's why I have changed the color here. And acetabular rotation. So these are two important factors of acetabular coverage. We have 15% and 11%. But these are asymptomatic population. Acetabular rotation, crossover sign, ischial spine, posterior wall sign. All are indicate acetabular rotation is R. And the third part is femoral neck junction, that is pistal drift and alpha angle. So we have very small actually, as far as I told you, the pincer was much more common in our country than the cam type. So we had a very small percentage here. So this is the way we classified, and this has been published already in Journal of Orthoplasty, one of the mind-blowing paper from our country. So in conclusion of that study, which I don't have to go into detail. So thank you for the Indian Society of Hip and Knee Surgeon allow us to do this type of work in this country. And these patients are now, we are documented from all the centers, and next 5 to 10 years, all these patients will be coming back because of the young patient. So we got all the patients' contact number, addresses, mobile, everything from all the centers. Our data is there, and after maybe 5 or 10 years, somebody will come out, whether they